Okay, good. Thank you very much. So thanks so much for the invitation to talk to everybody here tonight. You know, it's always nice for me to speak about vaccination because this is obviously my passion. So yeah, and maybe everybody is a bit tired after COVID-19, but nevertheless, you know, it's still very important, and yeah, we need to all work hard on this whole topic. So I'm going to start off, as you know, we're going to talk about the challenges and opportunities for us as healthcare workers. So it includes everybody working within the healthcare sector. So in terms of the presentation outline, we'll look a bit about what we know already over the years. What are the challenges? Just a little bit on COVID-19. Then looking more at, as Refuel said, vaccine hesitancy and confidence in vaccination. Moving then on to communication and trust. And then lastly, what opportunities are there for us as healthcare workers? Now, you know, with the success of vaccines, it dates back to 1796. So long ago, I can't even, you know, pronounce it. 1796, when Edward Jenner developed the first vaccine. So thanks to vaccination, smallpox was then the first disease to be eradicated in 1980. And today we know that vaccines save over 4 million lives each and every year. So also in terms of the success of vaccines, we are on track to eradicate polio with the endgame strategy. And South Africa had its polio-free status withdrawn in 2017. But if you look at this article, after a number of gaps were identified, so it wasn't because there was polio in the country, but there were certain gaps that we need to rectify to make sure that we do not see polio in South Africa. And after that, our status was then regained in 2019. But the fight is not over yet. So what we have seen in early this year is that wild polio virus cases were identified. One case firstly in Malawi, and then there was also in Mozambique, and that was also followed by a case which is quite, you know, strange and shocking, can I say, in the US. And that was, as you can see in this article, it was really bad news. And COVID-19 has actually shown us that, you know, it's very difficult to limit the spread of any pathogen by, you know, putting some restrictions on borders. It just doesn't work that way. So if you go and look at the WHO website, then you will see, you know, they document the cases that's been reported. And I mean, Malawi and Mozambique is actually very close to South Africa. Although there's still only there's two countries that's still endemic in terms of polio. So for the whole world, we won't be able to eradicate it until we know it's not endemic in those countries anymore, in Afghanistan and Pakistan. Now, polio is also very topical at the moment. And next week, Monday, will actually be World Polio Day. So there's a lot being done. And I encourage all of you, you know, to take part in this whole drive about creating awareness about polio, to making sure children are vaccinated, everybody's up to date with their vaccines. There's also a huge drive by the Rotary Club, and we as SAVICs also participating in this drive on Saturday. So very topical at the moment, very, you know, very relevant. But yeah, what about other diseases? So if we now move on to measles, and we also know the success of measles, and measles is, you know, the most contagious disease. It's very dangerous for children. And if we look, you know, back over the last 20 years, then you can see measles vaccination has prevented 31.7 million deaths globally. It is absolutely significant. And you can see on this graph as well how the measles cases came down since the introduction of the measles vaccine. But now also what we have seen, and especially in high-income countries, we've seen a rise in measles cases. So if you have a look at this graph here on the left-hand side, then you will see it. And this is very unfortunate because we have now seen an increase in cases globally, and as high as 700% in Africa and 300% in Europe. So this is very disturbing. While we should be seeing, also eradication of measles, we are seeing these outbreaks over the last number of years. So as a result of that, the and also other vaccine preventable disease outbreaks, and especially, as I said, in high-income countries, the World Health Organization actually in 2019, January of 2019, they identified vaccine hesitancy amongst the top 10 threats to global public health. So that already happened in 2019. But little did we know that in 2020, we are going to be faced by another pandemic. And as you are all very familiar with the COVID-19 pandemic. So what happened as a result of that? Vaccine hesitancy became actually a more serious problem. So in 2019, a lot of people was actually, pulling up their eyebrows saying, vaccine hesitancy. But as I said, little did we know what was lying ahead for all of us, and vaccine hesitancy has now really become a more serious problem. So also, if you look at this article, so we have the evidence that we need vaccines to prevent deadly vaccine preventable diseases if we look at the success of vaccines. But as Edwin Chen has stated, what is the point if people do not want to use these very same vaccines that we know are so effective? Now, if I look at the global progress in terms of measles as well as other vaccines, amid the COVID-19 pandemic compared to 2019, an additional 3 million children missed their measles vaccine doses. So we have seen measles cases increasing globally. And this is actually described by the World Health Organization as well as by UNICEF as a perfect storm, increasing the risk of large outbreaks and putting millions of children and adults at risk. So while the pandemic precautions have been relaxed, such as the social distancing, mask wearing, and so forth, the measles virus now actually has the opportunity of spreading much faster amongst the unprotected communities. So if we look at the global immunization coverage in 2020, which was now during the pandemic, the third dose of DTP, DTP3, it dropped from 86% in 2019 to 83% in 2020. So this means that 23 million of children under the age of 1 did not receive their basic vaccines, which is the highest number since 2009. So you can really see the impact. And the number of completely unvaccinated children also increased by 3.5 million. Now, zero-dose children is something that we need to take note of now. So they will refer to zero-dose children in future. And that means it's children who have not received their routine immunization, specifically the first DTP containing vaccine by the age of 1 year. So those children are then identified as zero-dose children. Then they also speak about zero-dose communities, because sometimes you get in certain communities where children are not vaccinated. Now, if we look at measles, as we've seen here in Zimbabwe, they say that about 750 children has already died because of a measles outbreak now quite recently. And then there are also other disease challenges that I didn't even include, like monkeypox. We now know of Ebola, and for that specific strain, we don't have a vaccine. And as Professor Mardi has said here in this article, that South Africa should be really concerned about these measles outbreaks, so very close to us. So it's not only for other countries, but also for South Africa to look at. Now, if you look at this is from the NICD website. There are also other outbreaks in South Africa. We've had a couple of cases of measles, not as bad as Zimbabwe, but then we also had an increase in the number of cases of pertussis in South Africa. And if you look at this graph here at the bottom, you can see, the increase in pertussis. So these are things that we must, take cognizance of. Now, in 2019, there was a national household coverage survey. I don't know how many of you know about this survey. So the data collected there were collected from children by looking at their road to health cards, basically by knocking at the door and then ask for the child's road to health card. Now, the data was basically collected on what happened in 2019, going back, and 2018. So as you can see here, that 83.9% of children received all their basic vaccines just up to the age of, just up to the measles 1 vaccine, which in the public sector is at the age of 6 months. That then dropped to 81.4% up to the second measles vaccine. Now, if we look here on the right-hand side, we look at whether children have received all the age-appropriate vaccines by the age of 18 months, that dropped to 76.8%. Now, I didn't mention it, but the World Health Organization targets for uptake is 90%. So although these sound quite good, we are not reaching our targets. Also, we must remember these are, overall percentages. So you do get certain provinces, certain districts where the uptake is much lower. And then in those provinces and districts, that's then where you find unvaccinated children. And if there is an outbreak, then they are the ones who will be highest at risk. Yeah, you can also see some reasons for misdoses. And in this survey, which was done in 2019, most of the reasons provided is actually more related to our healthcare system, providing healthcare, and then also to do with the vaccinated. And then one of the most common reasons was that they were saying that there was no stock of the vaccines, which is something that's going to be investigated further. But keeping in mind that this now happened in 2019. So if we look at the Department of Health routine administration data, you will see here that, going over the last number of years, South Africa steadily increased their total number of administered DTP1 doses over the years. And, looking at the overall coverage, it's 90%. So this is based on, routine data that's being reported. So this is not based on household survey data. And as you can see there is a difference, in these numbers. But then also looking at zero-dose children, although our zero-dose children also came down over the last number of years, we still have 9% of children that in South Africa, at high risk because they haven't received their basic vaccines. And if you look at this number, 9% is very high if we look at zero-dose children. So this is quite, a significant and a very important concern. Now, with the COVID-19 outbreak, the historical evidence of the success of vaccines actually gave us hope that we will be able to get a vaccine for COVID-19, we'll be able to get a grip on this whole pandemic. However, while we were waiting for these vaccines to arrive, then we were faced with another pandemic or an epidemic, and that is the epidemic of uncertainty. And this is very important for us as healthcare workers moving forward, is to understand this whole uncertainty with regards to vaccination. And all of this happened thank you to conspiracy theories, to rumors, which then fueled vaccine hesitancy. Now, with these conspiracy theories, they resulted now in people being less confident about vaccines. And this is actually as deadly as the virus itself. And we're all very aware of all the conspiracy theories going around, microchips, 5G towers, population control. I mean, we heard all about these things. I mean, also, to ask this question is Western countries, if they really wanted to kill Africans with the COVID-19 vaccines, in order to fully control Africa's resources, why did they then over-vaccinate their own populations and not provide, vaccines to African countries? So that's just a question that we can actually ask around these conspiracy theories. Now, despite these vaccines being available in South Africa, as you're all aware, uptake is very low. And here you can see how our uptake has now come down to really, I would say, rock bottom. And only 46.9% of our adult population is being fully vaccinated at this point in time, meaning that they have received the primary series. And those who are most at risk is our elderly over the age of 60, and that percentage is only 67.3%. So this was reported in a recent study that was conducted in South Africa to identify independent predictors of vaccine hesitancy. So what can predict vaccine hesitancy? Because we're now very aware of it. And they then reported that the most significant predictor was the concerns about side effects. So if you look at all the surveys that's been conducted, always the concern about the safety of the vaccines, the concern about the side effects would always be the most important factor or reason that people provide in terms of why they don't get vaccinated. And as you can see, there are some other reasons then also predictors that they have also identified. So let's just take a step back and look at vaccine hesitancy, just to make it clear again. So vaccine hesitancy, we must remember, it is a delay in the acceptance or the refusal of vaccine, despite the fact that these vaccines are available. And it ranges from delaying the vaccination to refusing the vaccination. And it can also be very vaccine specific. In other words, people can be hesitant towards, a certain vaccine, so for instance, the COVID vaccine, but not in terms of the measles vaccine or the influenza vaccine or vice versa. It's influenced by multiple factors, and we're going to look at them now. It's highly dependent also on the context, where people live, where they stay, where they work, where they operate. So yes, we need to understand that vaccine hesitancy is not the same as, anti-vaccination. These things are completely different. And, the largest percentage of people who don't vaccinate are those who are vaccine hesitant. And those are the ones that we need to target as healthcare workers. Now, research over the last number of years has shown that suggests that there are 5 drivers of vaccine hesitancy, and we commonly refer to them as the 5 C's, as you can see here on the slide. So confidence, firstly, refers to the trust in the effectiveness and the safety of the vaccines, like I mentioned, very important. Also, the system that delivers them, the health system itself, as well as the people motivating for specific vaccines. Then we get to complacency. So complacency exists where there's where the perceived risks of a vaccine-preventable disease are low, and vaccination is not deemed to be necessary for people to actually take that action in terms of prevention. Then there's calculation, at the top. So calculation is about seeking information about the vaccines, and then the weighing about the risks and the benefits, and then making that calculation to weigh the benefits against the risks. Then there's also convenience or constraints, and they refer more to the structural or the psychological barriers to people to actually convert their intention to get vaccinated to actual behavior. So you find a lot of people would say, yeah, I want to get vaccinated, but I am waiting to see what's going to happen. But then there's also other factors, like, for example, is it easy for people to get to a vaccination site? Can they communicate well with people at the vaccination site? Do they understand all the information? Can they speak and understand the language? And then there is risk calculation. So this is then where people, like I said, where they look at, they weigh the benefits against the risks, and they calculate to see whether should they do this, and how are they going to make they try and make a more informed decision by doing these calculations. And then collective responsibility is about understanding the value of vaccination for creating herd immunity. So we've learned a lot about herd immunity over the COVID-19 pandemic. So it means I don't vaccinate only for myself. I vaccinate for everybody around me, or for the person who might be at high risk sitting next to me or standing next to me. So these things are important to keep in mind, but this is now also very interesting. So we want people to accept vaccination, and there's been some research done in this area as well, specifically by Professor Charles Wissonge's group in Cape Town, and they have actually shown that a person's own worldview also influences vaccine hesitancy, which is very interesting. So there may be two potential pathways through which different factors interact to influence vaccine confidence. So with the neoliberals here on the left-hand side, believing that individuals must assess their own health-related risks, so they must make their own decisions about their health. And this worldview is often in conflict with, how we promote vaccination, how we send out messages. So normally these messages would tend to, inform, or they are informed by other discourses, such as a generalized risk and generalized safety and statistics and so on, and asking people then to trust the authorities who are making these decisions about the vaccines and who are, providing the vaccines. So that's the neoliberal logic. Then on the other hand, social exclusion are those experiencing, social exclusion, whether it's now economically, or whether it's socially, whether it's politically, and they may then lack trust in the government, and they may feel alienated, resentful, demotivated, and frustrated. So these things we also need to keep in mind when we are speaking to our patients. Now, something else that is very, very important, which is something that we need to keep in mind, and I mean, it's one of the drivers of vaccine hesitancy, is people's perception of risks. So when they need to make a decision about vaccination, then, and as I said, Safety is always one of the most prominent or common reasons for people not wanting to vaccinate. So a key factor is then this perception of risk regarding both the disease as well as the vaccine itself. So a person may believe that a disease is unlikely or not very serious, and at the same time that the side effects of the vaccines are probable or serious. So the basic formula that people then would use for assessing this risk always comprises of these two factors. So the one is the probability. For example, how likely is this, to happen? How likely is there going to be a side effect? And then also severity. So if I do get a side effect, how serious will it be? So they always make this calculation in their mind. So as a general rule, if a person perceives the risk of the disease to be high, they are more likely to be vaccinated or to take their children for vaccination. But on the other hand, if a person perceives the risk of vaccines to be high, they will be less likely willing to vaccinate or take their children for vaccination. So, because vaccination is one of the most successful and effective health interventions ever, and they manage to control many of these vaccine preventable diseases. As a result, we don't see a lot of these diseases anymore. People rarely become aware of them. And therefore, some people, their whole fear about vaccines, the fear of the side effects, has now actually replaced the fear of this disease that they have never experienced. So, many people have never experienced, many of these diseases. So they don't think about them. And now the whole fear about the side effects or possible side effects of vaccines now replaces that fear of the vaccine preventable disease. So it's very important that when you speak to people, that you need to always keep in mind that you have to bridge this risk perception gap. And it's difficult to do that because for us as healthcare workers here on the right-hand side, we base our assessment of risks and we make our decisions based on the latest evidence, based on science. So on the other hand, people out there, the public, they base their decisions more on emotions, on cognitive biases, on information that they get out there that's available to the public. And this creates this whole, difference in risk perception. In other words, a gap between these two groups. And then we need to think, how are we going to overcome that gap? So firstly, very important when you speak to people, to a person, listen and try and understand what are their concerns. Don't just make it off, that this is not important or they are silly to feel like this. Try and understand why are they feeling, that way. So the next one is credible information. We need to make sure we have the science background, that we provide people with credible information and stop, in other words, misinformation being spread. Then we need to be transparent. So we need to be honest. We need to tell people, what should they expect and what to do should anything happen. And always, not to hide anything from people in terms of vaccines and side effects, because that will just make them feel more uncertain. And then the last one is trust and respect. So you have to create trust between you and your patient or caregiver or vaccinee for that matter, and not to be judgmental and not to just discredit their concerns, make it off, this is not important. So it's very important that we create that trust and then communicate, like I said, what should they expect. If you don't do that, and they do experience, a side effect, then, that trust will be ruined, broken. Now, talking about transparency, so an example of this is during the pandemic, we quite recently identified 2 cases of Guillain-Barré syndrome, which unfortunately led to death, and we had to be transparent about it. So SAPRA, as responsible for ensuring the safety and the efficacy of all medicines and vaccines available in South Africa. So they actually put out a media release to inform the public. So when something like this happens, you shouldn't hide it. But then very important also to educate people, because it's very important for people when they start doing that benefit risk calculation, that they understand that this is very sad that it happened, but it's a very, very, very rare event. And you can only pick up these rare events when you are already administering these vaccines in billions of people. And this is exactly what happened in this case. But the positive side about this is that we could actually illustrate that we do have a safety surveillance network or system in place in South Africa, and we were able to pick up these cases, and we were able to inform the public about it. So if I now go back to healthcare workers, now healthcare workers is a significant source of information and trust, which is one of the building blocks, or the blocks that you need to build your bridge with to, to bridge that gap, especially when it comes to risk perception. And healthcare workers are regarded as the most trusted source of information when people seek advice regarding, vaccination and even other health matters. So it's very important that we need to make sure that we always maintain two-way communication, and that we create trust, maintain trust, as well as respect. And the dialogue must always include, like I said, emotional elements. Use personal narratives, use your own stories when you speak to your patients. Use evidence-based, communication techniques, and also use evidence-based information, and never be judgmental, because we want people to accept vaccination, and then, as a result, strengthen, maintain, and, maintain and regain confidence in vaccines and the whole immunization program. That's the ultimate goal that we are working towards. And that's where healthcare workers can play such a significant role. But we must also remember that healthcare workers are not immune against vaccine hesitancy. Even you yourself might have felt at some stage, now I don't know anymore, I'm not so sure anymore. And this is also a study that's been done, and they found that the most hesitant healthcare workers were also those that didn't trust the vaccines. So they also found, interestingly, that those who were more likely to accept vaccination, and we also see this in the general population, where the older people, they found physicians were more likely to accept vaccination compared to other healthcare professionals. And they also found, identified certain predictors of vaccine hesitancy. Religion was an issue, benefits and the whole consideration, the weighing up benefits against the risk, the willingness to protect others. So if a person is willing to also think in terms of herd immunity, that was also a predictor of acceptance, and then together with that, the collective action. So healthcare workers need to be empowered, and this is why you guys are obviously on this platform tonight, because you want to empower yourself with knowledge, skills, and confidence, and yeah, so this is really very, very great. And it's something that we need to work towards, and also to train healthcare workers on better communication, or to provide people with skills to actually communicate, because sometimes we don't know how to communicate. Now, as I mentioned earlier on, with the COVID pandemic, we were also faced with another pandemic, and that is the infodemic. So we were flooded with information, which is also one of the reasons why sometimes healthcare workers themselves can be hesitant, because there's just so much information and they are so busy, and especially in the pandemic, they worked such long hours. There was just no time for them to sift through all these loads and loads and loads and loads of information. And I mean, we do get misinformation, which is false or misleading information, disinformation, which is false information that's purposefully shared to mislead others. Then we get these conspiracy theories, you know, what I spoke about. And then there are also fake news. So that's fictitious information that, you know, parades as genuine news. And all of this leads to vaccine confidence decreasing, vaccine uptake decreasing, and then we see outbreaks of vaccine preventable diseases. So we need to be aware of all of these. So I just want to quickly show this to you. They have identified that there's actually just 12 people who's responsible for the vast majority of information being spread on social media. So they are actually the originators of this, and we refer to them as the disinformation dozen or the dirty dozen. So why I'm showing you this is, if 12 people can make such a huge, you know, such a huge impact, what can, I mean, if we talk about pharmacists tonight, but I mean, I'm also talking about all healthcare professionals out there, you know, we can also make a difference. This is just a study that we've done, where we looked at things like ivermectin and hydroxychloroquine and colchicine, and what happened in social media when people were talking about these things. And we looked at how, you know, the procurement or purchases went up, and we've seen indeed that, you know, it went up the more people were talking about it on social media. But what I actually want to show you is that the information that was spread around ivermectin and hydroxychloroquine and colchicine, it wasn't spread by healthcare workers. Less than 10% of healthcare workers were actually engaged with these conversations. It was spread by other people. So in other words, people who are not healthcare professionals, who don't have the necessary knowledge, they were the ones, or are the ones, busy educating the public out there. So just think about that. This is my second last thought. Our next pandemic that we are facing is the pandemic of antimicrobial resistance. And the World Health Organization is also on a drive in putting strategies in place. And, you know, vaccines, which is also one of my interest areas there specifically. Vaccines is a vital pillar of to fight antimicrobial resistance. But this is a topic for another day. So my last slide, just in conclusion, is you know, how do we bridge this gap of vaccine hesitancy? What can we do as healthcare professionals? Firstly, we need to make sure that these vaccines are available, that people have access to them. And we can also do a lot in terms of that. We've seen it in the pandemic, where everybody actually, you know, just stood up and, you know, stepped up and helped to make vaccines accessible to people out there. Then information and communication, I've spoken about it already, evidence-based information and the way we communicate with people. Then we need to make sure that us as healthcare workers are empowered ourselves with knowledge and with skills to be able to speak to our patients. And then the last one, very important one, is to make sure that we build trust and we build confidence and we build that relationship with people, and not only your patients, also your family, your friends, your colleagues. We need to look far wider than just the patient in front of us. And that's the way that we as healthcare workers can actually bridge this gap so that we can move everybody onto the left and get everybody vaccinated in terms of all vaccines out there. So thank you very much for listening, and I hope we have some time for questions. Thank you very much.
Thank you, Prof. We welcome the presentation, very informative. We welcome it. Whilst you grab a glass of water, we've been talking a lot. Let's we have a guest from a former WHO country rep. She's currently now the Rotaries End Polio Now coordinator for 15 countries in Eastern and Southern Africa. So she's here today. Can we just get maybe a commentary from her? Dr. Stella, are you around? Can you hear us?
Yes, I can hear you. Thank you so much.
Welcome to South Africa.
It's my pleasure to be here. Actually, I get crashed into this meeting because I didn't have the number, what is the number that they require that you to fill in the registration form, and I put 1, 2, 3, 4, 5, 6.
Counseling.
Yes, and so I got registered for it, but I'm so glad to be here because it's with pleasure that Rotary will partner with SAVIC on Saturday for this vaccination drive and awareness raising. Professor Meyer has raised very vital points with regards to vaccination in general. And I know that there are many South Africans, even Rotarians in our clubs, who say, are we still talking about polio? We thought we eradicated it. Well, we've been talking about polio eradication since 1985, when Rotary started Polio Plus. And in 1988, when the Global Polio Eradication Initiative was created for partners, we really thought by 2000 we would be done, but we are not. And there's so many reasons, and she's given so many reasons why we are not there yet. I think one of the most important things we can continue doing is to raise awareness, to tell people that until every child is vaccinated, every child is at risk. And that's the message. Until everyone is vaccinated, every child is at risk. So what's happening in Afghanistan and Pakistan, we are so far away from them, but the virus, the infection that turned up in Malawi last year, 2021, was a strain from Pakistan, and the child had never left Malawi before. So diseases move, travel, the world is a global village. We can't sit here and think we are safe, that diseases will meet us here. And now Malawi is a little further. We have 7 cases of wild poliovirus paralytic infection in Mozambique. Mozambique is a bus ride away from here. We have lots of travel between countries, and therefore we all should be singing from the same hymn book. People should vaccinate their children. As long as there are some children who are not vaccinated, every child is at risk. Now, finally, we think it's only children who get polio. No, the case in New York City is an adult male, unvaccinated, who has got wild poliovirus paralytic infection. So adults can get polio. And therefore, if we can, even adults should go out there and get vaccinated, especially if they think they're at risk of any sort, either traveling or whatever. We were going to Abidjan in September, and the travel clinics here advised that people be vaccinated, adults take the polio vaccine. And therefore, as a health workers, I'm encouraging you all to think vaccination. Why we know the problems are there. There's vaccine hesitancy, there are the anti-vaxxers, but really, truth remains that vaccination has been the single most efficient way of curbing disease the world has ever known. So I want to wish us all the best and thank you. I'll see you all on Saturday. Thanks.
Thank you
Yes,
so much.
Dr. Stella. Dr. Stella, can I stress you with this question? And then also I'll hear
Please
what
do. Please, I don't get stressed very easily, but try.
There's Olga on the chat, and she's saying some hospitals in South Africa no longer provide polio drops because South Africa is clear from polio. How would you like to address that matter?
Actually, we have addressed it already because we said there are many people who think polio was eradicated. It is not. Africa was certified wild polio virus free in 2020. That was after the last country, Nigeria, had not seen a case for 3 years. 2020. Then 2021, Malawi had 1 case. 2022, Mozambique has 7 cases. Do we know what is happening in South Africa? I was talking with Professor Meyer the other day, and we agree we can only see what we are looking for. So if your surveillance is good enough for you to catch the paralysis, then you know whether you have a case. It doesn't mean that because we've not seen paralytic children, then there are no cases. We just might not be looking for them. Therefore, with the knowledge that we have that vaccine coverage is not optimal, we can be sure that we might have cases that we do not know about. And so let us preach the word that polio has not been eradicated yet. And until vaccination, all children can get a vaccine. All children are at risk. Thank you.
Okay, super. I think, Prof, Mayor, you may unmute. I see you are talking there, Prof.
Okay, there we go. So I saw, I'm trying to scan through the questions, and if we don't have time to answer them all, I'm happy to answer them afterwards, you know, in an email or whatever. But with regards to the polio drops, I've seen people asking that they are not available in the private sector at the moment. So at the moment, the polio, the oral polio is coming in with a Section 21 permit in South Africa, because there are very few countries actually still using the oral polio as part of their basic immunization schedule. But once you know the problem has been sorted to get the vaccines, then I'm sure that the problem will also be solved in the private sector. So I'm not, you know, familiar with the whole procurement process and so on, but I would say that they should actually try and refer their patients to the public sector to get the polio drops from there. Yeah.
Thank you, Prof. Let me start with the questions. We only have a few minutes left. Dr. Mawela, do you want to ask, or are you fine?
No, continue. I think we should go through the Q&A so that we see how far we can go. Yeah.
All right, thank you. Prof, the first question is there any research done with regard to COVID-19 vaccination side effects? And if so, what are they? Thank you.
Yes, indeed. So very important. So the way that we know about the side effects, so the side effects are being researched during clinical trials, but now we are post-marketing surveillance. So any side effects must be reported through using the Med Safety app. So you can go to the SAPRA website where you'll find all the information, and then report through the Med Safety app or at a healthcare facility. This can also be done on a paper-based form. And then all our data, together with 4 other countries at the moment, gets pulled together as part of the African Union Smart Safety Surveillance Program. And then that it helps us, because now we have a lot of data to run, we call it like signal runs, to identify if there are any concerns. So at the moment, we know about the side effects already from the clinical trials. And the most common ones that we know of is like headache, fever, you know, a sore arm, swelling or redness at the injection site, body aches, but those are mild ones and they should disappear within the first 3 days. And there are also these more serious ones, but they are very rare, so we don't see them often. But the most important thing is to inform people if they experience anything of concern, please seek help immediately. Don't think, it's this or it's that. If you don't feel well, you don't feel normal, your fever is not going away, immediately go and seek help. Thank you.
Thank you, Prof. In SA we have load shedding. So most of our clinics are affected by load shedding as well, and they go without power for longer periods. So what is your take in terms of vaccine potency? And how many of those vaccines end up given to children? Will that not disturb coverage due to poor quality vaccines? Thank you.
Yeah, well, a good thing about the COVID pandemic is that, the cold chain has been strengthened a lot. There's also a huge project at the moment. It's going to, I don't know whether it started yet because I'm not working for the Department of Health, but I know there's a lot of resources being poured into cold chain management. So yes, I agree, at the moment we are faced with all the load shedding, but hopefully our healthcare workers are not administering any vaccines which is gone, which is now beyond what's been exposed to temperatures, higher temperatures, looking at the vaccine vial monitor. But yes, yeah, so I do agree it is a problem. And if you're a healthcare worker and you're in such a situation, make sure that you get a generator and all the necessary things. But as I said, definitely I can also provide the details of the national cold chain manager, so you can always contact her as well.
All right, thank you.
There's a problem, yeah.
Yeah, this next one I was not aware of, but hopefully you'll give us an answer. There are regulations in South Africa that prevent clinic nurses from prescribing Schedule 3 vaccines. So those patients expect to get their prescription from the doctors. Are there any special allowances for private sector vaccinators to overcome this barrier? Thank you.
Yeah, so yeah, I think this is a bit of a difficult question to answer, especially for clinic nurses. I can actually speak in terms of pharmacists. That I know for sure that for pharmacists to vaccinate in future, they need to do a certain qualification accredited by the Pharmacy Council, and then get a permit to be able to practice as a vaccinator. But yes, for other vaccines, where it is a Schedule 3 or higher, then yeah, there is a prescription necessary. But yeah, I can, I can't answer that question, but at the moment, according to my knowledge, that is unfortunately the case. So say, for instance, you need varicella vaccine, then you need to have a prescription if you're going to the private sector clinic to go and get that vaccine.
Okay, thanks, Prof. I thought nurses those ones who are qualified as PHC pharmacists can prescribe up to Schedule 4. So I stand corrected because I know that we have nurses that can prescribe up to Schedule 4, they're allowed. So if vaccines are Schedule 3, then they should be allowed. But yeah, it's something that we need to look into. Yeah.
Yeah. I'm not 100% sure about that one, yeah.
Yeah. The next question, I think it's similar to the polio one. Do we have any measles cases in South Africa, confirmed ones in South Africa?
Yeah, well, there was recently reported on the NICD website. I think it was 3 cases or so. But every now and again, we do get and it usually happens in a small community where, there are under-vaccinated children. But yeah, I mean, there's no huge outbreak, but they are planning a measles catch-up campaign as well, the National Department of Health.
Okay, thanks, Prof. So this question is twofold. Do we have more cases that are reported that are vaccine related? And also, what other strategies do you think are best for healthcare workers to convince the public to vaccinate their children?
Well, the thing is, yes, you know, it's not that easy just to you know, to convince somebody. So in terms of your communication, it's always the best to use a presumptive approach. So that means you are presuming the person wants to vaccinate their child. So you would never say, what do you think about vaccines? You would rather say, oh, I see your child is due for the vaccine today, let's vaccinate. And then, you know, there are different techniques to convince, of which one of them is a motivational interviewing technique. So basically, it means you're going through this whole process of trying to understand what are their concerns, to allay their fears and explain this to them. Because often it's just a mere fact of people not having the correct information and not understanding, and that makes them feel insecure. So I would say communication is the most important, you know, way in which you can convince people to get their children vaccinated. It doesn't help you show them pictures of people with smallpox. That actually scares people even more and make them even more, you know, hesitant and concerned. The best way is to get that communication going.
And maybe just as a quick follow-up, Prof, in your slides you have covered it, but I've noticed that as health workers we tend to withhold information, especially around side effects, because we feel we don't want to scare the client off. But I saw in your slides you have covered that it's actually best, so that even when these side effects happen, then at least there's trust in the relationship. Yeah.
Yes. And then to tell them, you know, take your phone, use the Net Safety app. It's available for iOS and for Android phones, and report any side effects. Or if you have any concern, come back. But yeah, very important to, you know, to inform them and not to lie and say, you know, these things don't have any side effects. I mean, all medicines also have side effects. So, but people take medicines because they feel sick, and it makes them feel better. So because they feel better, they are not so concerned about the side effects. They tolerate them. But when you are feeling sparky and healthy, you don't now want to have a headache or body aches or whatever for no reason, which is why people, you know, they don't tolerate the side effects of vaccines. And can I please just say this? There's a fake website called SAVERS, SAVAERS. Please do not report any side effects to them. They are not the Department of Health. If you're going to report to them, those cases will never be investigated. Those people will never get help. It is, please be on the lookout for that. Make sure you also inform people accordingly. I can just say the cases that's been reported of measles on the 11th of October is 3 cases. Yeah, 3 cases that's been reported of measles.
Okay.
To answer that other question, yes.
We're only left with a few questions. Just bear with us. And this one is more technical. If Marion was here, she would be able to assist. It's about Pfizer COVID-19 vaccine. When does it expire? Do you know?
I don't know what the new expiry date is, but they were due to expire, I know, some in September and some in October, but the expiry date has been extended. So can I also explain that quickly? Because people often now think, oh, now they are lying to us, and, you know, now they're giving us old things that's already expired, but it's not true. So normally when a vaccine comes onto the market, you already have, you know, at least a year or two data available. which was not the case with the COVID vaccine. So they were manufactured and immediately they were going out. So these vaccines are being monitored in real time, looking at the efficacy at the real life temperatures. And that is how they then determine the expiry date. So because we have now more information available and data available about the stability of the vaccines, that this is why the expiry date has been extended. So there's still vaccines now available, but please, there's many vaccines. People should go out there and get vaccinated.
Thank you, Prof. Our cold chain manager in the province has just forwarded me the latest circular. The last batch is expiring 31st of January, 2023. That's the latest circular. Thank you, Bonani.
That's good.
Yeah, and then the next question is monkeypox disease vaccine with regards to efficacy. Did you mention anything? Can you mention something on the monkeypox disease vaccine?
No, I didn't. I must be honest, I'm not very clued up on monkeypox vaccine because we don't have the monkeypox vaccine in South Africa available in any case. But I'm going to lie if I'm going to say it's this effective or not. So I'm sorry, I can't comment on that one.
Thank you, Prof. No stress. Okay. Johan says we want free vaccines in private sector. Can I tell you, Johan, that even in public sector, the vaccines are not free?
But yes.
Yes, okay. I was about to say, Prof, I think what he's trying to say is this collaboration with the public sector to increase access.
Yeah, and I mean, it is there. It might not be, what do they call it, plain sailing, but if you're a private sector facility, and please, I don't even want to say if you want to make vaccines available, I would like to beg you to try and make these EPI vaccines available in your private facility. Contact the district pharmacist, I think, or the district person, or contact me. I'll try and get the details for you. And there is a service level agreement. Each province has got its own service level agreement. So there's a service level agreement that you can set up. And then there's obviously certain requirements in terms of the cold chain. You have to provide data for your vaccines. You're not allowed to charge for the vaccines. You can only charge an administrative fee. So there are certain conditions, but yes, we want people, the Department of Health want the private sector to make these vaccines available. And going forward with the NHI, I think it will be essential.
Yeah, in my province, we're still under discussion. It's not yet in place.
Hopefully
we'll get there. There's the publishing of information relating to the negative effects of vaccines, e.g., letting the public know of vaccine deaths, do justice to the idea of preaching vaccination to the public, and do they actually getting the public vaccinated? How do we deal with that? The publishing of information.
Yeah, you know what? So I mean, I didn't even include it in my slideshow, but on the SAPRA website, there is a microsite. So if you go to the landing page and you go to, I think, electronic information, you will find the adverse events following immunization. So on that website, they show how many vaccines have been administered, and what the percentage of adverse events following immunization has been reported. This is not only for the COVID vaccines, but in the future, there will also be information becoming available on the other vaccines. So on that website, you can read more about adverse events. You can also, they provide information about the top 10 side effects being reported. So the person who, for instance, asked the question, please go to that website as well. But then the only thing that, they show gender, age, provinces. Also, they show in terms of deaths being reported, and then the causality assessment that's been done. But please keep in mind, This is spontaneous report, so it's what people report. So if I report something incorrectly, obviously it's going to have an influence on the data. But at the moment, the reporting rate is actually very low, 0.02% on average. So we want people to report more, because the more reports you receive, the more you can make sure that the vaccines are safe. If people report and you pick up something, then you can do something about it. You know, we might not see the same things here in Africa compared to other countries, for example. I'm not saying it's going to be the case, but I mean, it's a possibility. So that's why it's so important that people must report. And, you know, we must inform the public about it, because vaccines are very safe, they are very effective, but there is this small possibility of very, very rare serious events. But, you know, you need to keep that risk-benefit balance always in mind, and that's why people need to be informed.
Okay, Prof, last two questions. Three questions, sorry. What's the difference between OPV and IPV, oral polio and inactivated polio? And why was IPV discontinued?
So the IPV is not discontinued. The oral polio is a live vaccine, and that has been given at birth and at 6 weeks. And it's given to babies because it provides very good gut immunity at that age, and also because small children, they are at highest risk, you know, should they get the polio virus to, you know, become very ill and even paralyzed and so on, or die. Then the IPV is part of the hexavalent vaccine, which is given at 6 weeks, 10 weeks, 14 weeks, and then at 18 months. So, and that's being used by most people across the world, but because we still, you know, in Africa, there's still those two countries, well, not in Africa, but Afghanistan and Pakistan, who's endemic in terms of polio, wild virus polio. And we have this migration of people all along throughout Africa. So until we've been able to eradicate polio, I think we will continue using the oral polio vaccine. And remember also, like, we've got a very good immunization program, schedule rather, in South Africa. Yes, a program as well, but not in all other countries, you know, are they giving the vaccines, you know, like we have the hexavalent plus the oral polio drop, which is why we need to protect our population by continuing with the oral polio, as well as the, and then also, I mean, for pregnant women, there's also a vaccine that also contains IPV, together with tetanus and so on, yes.
Yeah. Okay, Prof, this one is about stockouts of the Pfizer vaccines in the private pharmacies, clinics and discounts, but in Pretoria specifically. So the question is, can they be made available? If we have somewhere available in other sectors or in other pharmacies, can you make them available to the private sector? Because now they are not providing, National does not provide those vaccines to the private sector, they source them themselves.
Oh my goodness, yeah. So unfortunately, I'm not able to answer this question. I think we should refer that to the National Department of Health. I would say that. Who asked Johan van der Heever name?
Yes.
Okay, yeah, I know Johan. All right. Okay, so I will see if I can sort this out for you.
Thank you, Prof. Thank you. Last question for the oh, yeah, Johan is very passionate. She doesn't want us to go, but it's fine. This one is more personal. It's more personal. This person has a 5-year-old who developed urticaria post 3 months immunization vaccine. So they pushed him to 18 months with severe flares. Since the gap is cleared of the urticaria, and now she's very reluctant to take the child back for vaccination. What would your advice be?
Okay, 5. So is this child now 5-year-old?
Yeah.
So, yeah, you know what? I would recommend it. It seems like this child has got some allergies, you know, hypersensitivity. It all depends on which vaccine it was. Also, when the child actually developed this urticaria. But I would say to take the child to you know, a specialist in allergologist, because what they would then do is they would determine, you know, which antigen it was, or try and determine that, and so on. And then they would then look and see what they could do in some instances, like what they've also done with the COVID-19 vaccines. They would, for example, first administer an antihistamine, and then they would administer a small dose of the vaccine, observe the child, and then administer a further dose, you know, until they've given the full dose. But there are ways in which they can work around it. But I would recommend to go and see an allergologist, you know, but please try and get the child vaccinated. Very important.
Thank you, Prof.
Okay, you are asking, when are we introducing rubella vaccination?
Yes. Yes.
That's the last one for the night.
Yeah, let's hope in 2040, 2024. Yeah, I don't think it will be 2023. I anticipate 2024, but it's going to come. Yeah, that's a good news.
Superb.
Yeah. Thank you so much, Prof.
Before Refilwe closes, Prof, I wanted to just check. So I'm a hesitant health worker, or I know a colleague who's hesitant. Where do I start with my transformation journey? I think this would be your closing remarks, Prof.
Are you yourself, or you know someone who is vaccine hesitant? No. So if
so I'm just giving a scenario. Yes.
Yeah, if you yourself is vaccine hesitant, I would say, you know, start off by speaking to someone who is knowledgeable about the vaccine, so that you can have this conversation and you know, clear all your uncertainties and questions in your mind. And the same with a colleague. Try and speak to the person and try and find out, you know, what is bothering him or her, what is a problem. Try and understand the problem, and then, you know, provide the evidence-based scientific information. Sometimes we are not successful, you know, first time around, can I say, but always keep the door open. Never say, go and find yourself another doctor, go and find yourself another pharmacy. Always keep the door open by saying, look, you are welcome. I'm always here. Let's discuss this again. Come with more questions. I'll try and help you, and so on. That's the best way to tackle that person. Not to get cross. It's not going to help. It's going to make it worse.